The first type is flooding. So what flooding is basically you have an anxiety disorder, maybe you have a specific phobia, like you're afraid of spiders. And flooding would involve, say, going to the therapist's office and having them take a tarantula and put it on your body and leave it there for like half an hour. And it turns out this can be a really effective treatment for phobias. It's very torturous. People, it's a very unpleasant experience. But if you stick it out, it can actually be extremely effective. There are actually known cases where people have cured, decade-long phobias in one session. Although that's not typical, but it really is remarkable how well this can work for a lot of people. Then there's this idea of, rather than flooding, of systematic desensitization. And the idea there is similar to flooding, except you sort of build up. Rather than starting at the hardest, stage 10, you start at stage 1, and you move progressively up to harder and harder things. So very often with this, what the therapist will have the patient do is make a list of fears that are rank ordered by how much they fear them. And then they'll have them start at the lowest level fear, do that thing, which might be, let's say you have a fear of spiders, that may just be imagining spiders. If you're really phobic of spiders, literally imagining spiders may cause you a lot of anxiety. And then after you've conquered that, either by doing it enough until you no longer were fearful of it, or maybe you've just done it a while and you feel ready to move on, then you might start viewing photos of spiders, and then after that you might, say, view videos of spiders, and then maybe you'll have a dead spider in the room with you, and then maybe a living spider, and then maybe in the end you actually will have the spider crawl on you. So that's the idea. Now, both of these techniques are effective. Systematic desensitization tends to be more humane, but can take longer to actually carry out. And so how do people view these therapies? Like, how do these therapies actually work? So one of the views that people take is this conditioning view. So this is a classical conditioning view, which sort of says, look, your brain has created some correlation between, say, spiders and something really bad happening. And just by putting you around the spider, we're going to break down that correlation because nothing bad's going to happen. The spider's going to be there, you're going to feel anxious, but there's no real negative consequence. And sometimes the therapist will actually get the patient to use relaxation techniques during the exposures, so it makes it even more positive association. So you feel more, rather than feeling absolutely terrified, maybe you'll feel less terrified around the spider, and maybe that will break the correlation faster, perhaps. I don't know. There's another view actually, which is to view this cognitively. So a cognitive person might say, well, what's really at stake here is your belief about spiders. You believe spiders are dangerous, and by sticking it out, being around spiders, you eventually realize that they're not dangerous. And so that's sort of a cognitive interpretation. I don't think it's really well understood exactly why exposure works. But one thing that is known is that there tends to be a burnout effect in that the first 5 minutes that you spend with a tarantula, if you're really afraid of spiders, you're going to be horrified. But 5 hours later, you might actually be bored. I mean, the brain can only, it sort of like maxes out, and then it's sort of like, okay, I'm not anxious anymore. And so this does seem to happen if you keep someone around in an exposure long enough. All right, so there's also an interesting idea of cognitive exposure, which is that you don't actually have to go do something for an exposure. You could just do it mentally. You could use visualization. You could imagine tarantulas crawling on you, and maybe this could actually work to cure you if you practice it enough over time. And it's actually particularly useful for things that are hard to simulate in real life. Like maybe if you have a fear of plane crashes, it might be hard to simulate plane crashes. Now maybe you could watch videos of them or something like this, but maybe a cognitive exposure would be helpful in that case as well. All right, so one thing to note about anxiety in particular is it tends to lead to avoidance behavior. So if say you have a social phobia, and every time you're put into a social situation that makes you uncomfortable, you just leave immediately. Now the effect of this is that your anxiety level is going to drop right away. And so what you're actually doing is you're giving a negative reinforcement to this avoidance behavior, because you're removing something that you don't like as soon as you avoid. And actually, this perpetuates the avoidance behavior. But it also prevents any exposure from taking place, because your brain's never able to learn that, hey, this thing isn't as bad as I thought. Now, how do I know that the thing's not as bad as you thought? Maybe your view on it is really realistic and your social situations really are horrible. Well, the fact is that very, very often when you're experiencing an emotional state like a phobia, you tend to distort reality very heavily. So it's almost definitely the case that in such a situation you're actually exaggerating how bad things are. So even if things are pretty bad, they're probably not as bad as you think, which is important to remember if you're actually trying to do one of these exposures. So there's also this question of how come exposure sometimes fails? So there are examples of, say, actors who claim that after a decade of acting, they still get anxiety every time they go on stage. Like, that doesn't seem to make sense. And there's different theories about why sometimes exposure fails. One of these theories is that it might have to do with the way the person thinks about the exposure. So let's say the actor, every time they get off the stage, they think, phew, I just avoided another disaster. I narrowly missed completely screwing up my career. Well, in that case, leaving the stage might not give them any sense that actually there wasn't danger there. It may actually perpetuate the idea that they were in grave danger, and maybe that's why in this case the exposure wasn't effective. But I'm not sure that it's really well understood why sometimes exposures aren't effective, although they do know ways of doing exposure that do seem to be effective, which is very nice. Sometimes when a therapist is working with a patient relating to exposure, they'll actually get the patient to make predictions about what's going to happen. So if let's say you're phobic of planes, you might actually think the plane is going to crash, for example. You make predictions about it crashing or experiencing severe turbulence or something else like that. And so by using the patient's predictions and then showing the patient those predictions after the fact, they can help illustrate to the patient how distorted their thinking really was. And so this could be an effective, like, sort of cognitive approach to getting the patient to realize that they are having inaccurate predictions about the world. All right, so let me move on now to the second technique I want to talk about, which is really related to operant conditioning rather than classical conditioning. And it's not necessarily considered part of CBT, but it's very related to CBT, and there are a lot of overlap with CBT, so I'm going to include it. And this is the idea of behavioral activation, which is a treatment for depression. And so the basic idea here is that you view the environment as being a reinforcer. And the theory goes that basically maybe a depressed person is getting too much punishment from their environment and not enough positive reinforcement. And so the idea is you want to try to increase the amount of positive reinforcement they're getting, you want to decrease the amount of punishment they're getting. And so let's take an example of a depressed patient. Depressed patients often will tend to think that they're not going to enjoy activities that they actually would enjoy. And so the depressed person thinks, oh, I know I have plans to go out with my friends, but I'm just not in the mood, I'm going to be a downer, I'm not going to have a good time. They don't go out with their friends. And this leads to an environmental punishment, which is that they end up sitting at home alone, which makes them feel worse. So then, in behavioral activation, what they might get them to do is actually go out with their friends, and because they tend to enjoy it more than they think, this actually could act as a positive reinforcement for going out even more and lead to this virtuous cycle of like better and better behavior. So an example treatment plan in behavioral activation is you might come up with an activity list with your therapist of activities that you think might make you feel that life is valuable, might make you feel good, might be positively reinforcing, and you might say rank order them by how difficult you feel it will be to get yourself to do them, for example. And then you might try, and maybe at the end of every session, set goals for what you're going to try and achieve that week on your activity list. And then you're going to track your progress. How well did you do? You'll report back with the therapist at the end or at the beginning of the next session. And yeah, so that's the basic idea. All right. So this leads me to the third method I want to talk about, which is part of cognitive therapy, and this would be cognitive therapy for, say, anxiety or cognitive therapy for depression. And so this basically would amount to trying to get the patient to believe the cognitive model that their thoughts are actually causing their emotions, that the thoughts are intervening, first of all, that the thoughts are possibly distorted, and then training the patient through the use of, say, exercises and homeworks and so forth to learn to start noticing the thoughts that they're having, learn to start challenging these thoughts, and ask questions. So there are a variety of very specific techniques. For example, they can get the patient to ask, what is the evidence for my belief? So if the depressed patient thinks they're not going to enjoy the activity with their friends, they could say, well, what's the evidence that I'm not going to enjoy the activity? What's the evidence that I might enjoy the activity? They might conduct an experiment. So the therapist would get them to say, okay, well, you think you're not going to enjoy the activity. Let's conduct an experiment. Let's actually, why don't you go out, try it, see how it is, and then we'll know for sure. Or learn to look for distortions in their thinking. So there are common distortions that the therapist might teach them about, and then they can start noticing them when they occur. And then also a really important technique is what they call rational responses, which is learning to basically challenge the thoughts you're having with true statements that actually run contrary to those thoughts. And the idea is that basically, when you learn to challenge these thoughts, you might actually be able to change the emotion that you're feeling. And so you might start by doing this, say, on paper after you have an experience that causes negative emotion, but you might progressively move towards doing it in real time, so that you actually can be managing your emotions as they're happening, for example. So that covers pretty much what I want to talk about. I'll just mention this book right here, which is very well read, as you can see, Feeling Good, which is the book that taught me a lot about cognitive methods. It's a really, really interesting book. It's not necessarily fun to read, it's quite long, but it has tons of useful tips, useful exercises that you can do to practice, and so forth. This was written by this fellow, David Burns. He also has another book called When Panic Attacks, which is about anxiety, and that has a lot more behavioral stuff in it, because behavioral methods tend to work really well for anxiety. So that's also a really good read. I've read that as well. Something to mention about this book is really unusual. So first of all, there was a 1994 survey done of 500 mental health professionals, and this was the #1 most recommended book among them for depressed patients. But even more interestingly, they've actually done studies on this book. One particular study they did, they had 80 patients who were depressed, according to whatever the criteria for depression was. They split them into 2 groups. The first group they had read the book over a 4-week period. They called them, I think, once a week to remind them to read it and talk to them for just like 10 minutes. And then the other group they told to wait and don't do anything until the end of the 4 weeks. And then they measured the 2 different types of depression scores before the 4 weeks, after the 4 weeks. What they found is actually had huge effects on people's depression. After 4 weeks, 70% of the 40 people that had read the book no longer met the criteria for depression, whereas only 3% of the waiting group no longer met the criteria for depression. So it's a pretty dramatic effect. After 3 months, it was 74% that didn't meet the criteria for depression. And after 3 years follow-up, it was 72% that didn't meet the criteria for depression. So it actually seemed to be quite effective. And there was also only 10% dropout in the study, which is really remarkable, because often therapeutic studies involve much higher dropout rates, which can really screw up your results. So thank you. Yeah, questions? Yeah?
When was cognitive behavioral therapy first introduced to the psychiatric community?
Well, cognitive stuff started being developed in like the 50s and 60s. The behavioral stuff was earlier, like maybe, I said it earlier, maybe like 20s and 30s. And then they sort of started merging at some point. I don't know exactly when that happened. People started picking techniques from both of them and putting them together and calling it cognitive behavioral therapy.
Okay.
Yeah, just to comment on the last thing you said, I recently read that there were actually 2 schools of thought, the cognitive school and the behavioral school. When they actually looked at that, in practice they were very, very similar, so they just merged them.
Yeah, I'd say some of the theories are different. Behaviorists tend to view everything from a behavioral standpoint. Cognitive people tend to view things from like, what are your thoughts, their cognitions. And so maybe theoretically they're quite different, but today you tend to get people doing both of these sets of techniques, not just behaviorism or just cognitive stuff.